On to you, Doctor.
Good evening, everybody, and thank you very much.
I'm sure Dr. George is known to one and all of us, the Chief of Glaucoma Services at Arvind Eye Hospital, Arvind Eye Care Systems, Madurai. And I'm sure he's going to have a very effective counter at this point.
Thank you very much, Chitra ma'am. So tube erosion is a concern when using an extraocular implant, and covering the tube with a patch graft is not a full insurance that you can avoid this. So here is a rare occurrence of a graft getting melted and the tube extruding. So I'm sure that many in this panel would have seen this over a period of years. The patch starts melting and we find the tube just lying underneath the conjunctiva. And most of them, yes, they do remain stable for years together with just the conjunctiva overlying it. So we will look at 3 study groups who have reported their postoperative complications over a 5-year follow-up, and all 3 study groups have used patch grafts to cover the tube. So this is the tube versus trabeculectomy group, and the tube exposure in TVT was 5%. 5 out of 107 patients in the tube group had to undergo a tube revision with new patch graft, after which 2 of these patients further had recurrent tube erosion, another tube revision, and 1 of these patients ended up with a removal of the tube. Coming to the ABC, the Ahmed Baerveldt comparison group, again reported their complications during their 4 years of follow-up. They showed 3% of tube exposure in the AGV group, 1% in the Baerveldt group. Revision for tube erosion was done in 2 of those AGVs. 1 of the AGV was explanted and 3 in the BGI. So the same patient had 3 erosions. Lastly, the AVB study. Again, 4% in the AGV group, 2% in the BGI group. Revision with patch graft, 2 in the AGV, none in the BGI. Both the BGIs were explanted. 3 of the AGVs were explanted. So tube exposure is a paramount concern when implanting the tube without a donor patch graft. However, all the studies, and this is precisely the reason why you don't see much literature, much of this technique. However, all the studies using modified scleral tunnels, which Ganesh just now showed, and flaps do not report an incidence of tube exposure of more than 2 to 3% in eyes without the patch graft. So this is this Felix Gil group from Mexico. They describe a technique of 22 or a 23 gauge needle generated 3 to 4 millimeter long needle track without fashioning a scleral flap or using a donor patch graft. They reported results of 128 Ahmed glaucoma valves in Mexican children with a mean follow-up of more than 2 years. They encountered tube-related complications like tube retractions, lens touch, transitory endothelial loss. But what was amazing in this publication was that the tube exposures were nil, and that too, it is pediatric refractory glaucoma, which we know the tube exposures are much more than the adult group. So what we are advocating today is this slight modification of this technique, a patch-free, a flap-free tube implantation through a 4 millimeter 23 gauge needle generated scleral tract. And we do a little bit of markings to ensure that an optimum 2 millimeter tube is left in the anterior chamber. We also mark the initial scleral groove to make sure that we get a 4 millimeter scleral tract to insert the tube into the anterior chamber. We also try as much as possible to get both in the right and the left eye. We try to fashion the scleral tracts medial to the original position of the tube so that the tube enters the eye at around 12 o'clock. And the tubes entering the eye at 12 o'clock have the minimum possible contact with the upper eyelid, thus minimizing the risk of tube exposures. So as Ganesh has already shown this, we have published our results. This paper has, we have tried to describe the surgical technique as best as possible with a lot of wealth of Professor Paul Palmberg's knowledge and experience thrown in the discussion part, where there is a lot of useful practical tips on how to get the scleral tract right and also how to get the tube as close to the iris as possible. This publication also has a link to a supplemental video which those of you who are interested could look at. So again, we saw that we didn't have any tube exposures in the non-patch group, both in the adult and the pediatric group. So in the adult, within the first year, we had 2 tube exposures. Pediatric, we had 5 eyes within the first year having tube exposures. So again, there are 3 things which I would like to highlight. There is less elevation of the ocular surface, much smoother, less inflammation and better wound healing with this technique. Again, a flatter transition between the conjunctiva and cornea, improving the lubrication at the limbus. Again, this is crucial to avoid tube exposures. And again, as Ganesh has mentioned, prevents micro movements. Having a tube snugly fit in a 23 gauge 4 millimeter scleral tract, the micro movements are very less. There are no micro aberrations. Also, you have the potential advantage of avoiding late tube straightening and the tubes getting close to the endothelium. We have tried to shorten the learning curve as much as possible. Most of our surgeons, just a single session in the wet lab, multiple entries, and we have also multiple entries into the anterior chamber to get this track right. We have also made some calculations on the needle to ensure that the tube lies as close to the iris as possible. See, I have seen a lot of debates. There's a lot of Photoshop work involved. This was one which Dr. Satyan showed in a recent AIOS-ARC debate, where you can see the RD implants on Kavita's ears. And probably the first time I didn't have to Photoshop my good friend and colleague, Ganesh, because this is something which we do day in and day out for the last 3 years. There is no Photoshop work involved in this. And also the topic is a modified technique saves the time and need for a graft. Ganesh was saying that I was going to throw a lot of things like prions and COVID at him, but these are all just fringe benefits. We are just bothered about safety, and then more about safety. And we truly believe that embedding the tube in patient's own sclera is the best way to avoid tube exposures. The only caveat is to get a scleral tract which is of sufficient length and depth to make sure that the tube is well buried in the patient's sclera. And we truly believe this. We have, even in our pediatric patients, the very young, this is the way to go forward to take tube exposures out of the equation. Thank you very much.
Thank you very much, Dr. George. I think both of you have given us all the information which we need in your brief debate. So I thought I will just go on to asking some questions rather than countering you all again and again. How would you diagnose and manage a peritubular leak, Dr. George?
Ma'am, it's actually a diagnosis of exclusion. The surgeon will on table intraoperatively would have known that there must be something wrong with the tract he has. I'm talking about these long scleral tracts. If it is a 23 gauge needle tract that has gone into the anterior chamber and has come out in the same path without slightly extending that tract, and it's highly improbable to have a peritubular leakage, because all modern glaucoma drainage devices, the tubes are designed to fit this 23 gauge needle tract snugly. So it's totally a question of exclusion. We need to look at other factors which can predispose to ocular hypotony.
Can I add a point?
Yes.
Thank you, madam. If you have made multiple attempts, that carries the risk of peritubular leaks. And number two is you can control the point of entry, but very difficult to control the point of exit. So that's another thing in multiple eyes which have undergone multiple surgeries. So if you have multiple entry sites, you must suture each site separately. And if they happen to go to the same channel, suture it very well. So that's the way to avoid. But the diagnosing, as Dr. George said, it is a diagnosis.
Dr. Murli, you have any other question before we go on to our next speaker? Murli, you have to unmute yourself. We can't hear you.
Yeah, can you use autologous sclera or Tenon's fascia if donor sclera is not available? Autologous sclera or Tenon's fascia if donor sclera is not available, or would you just recommend the needle track technique for? Because many centers may not have donor sclera access to donor sclera.
Yeah, I think it's possible. I have no experience. We always use donor sclera when we started off.
Only you could. There are surgeons who use. They fashion the scleral flap, just like your trabeculectomy flap. They raise the scleral flap and put your tube under that. But again, the ocular surface is raised there. And Tenon's fascia, I don't think so. You have to have some, unless you have a good long scleral tract, I don't think you can just leave a tenon fascia alone. You have to have a sclera attachment.
Yes. Thank you, Dr. George and Dr. Ganesh. That was a wonderful debate.